Good morning. Good morning and good afternoon to everyone that's on the line. We've been holding off for a minute or two to allow people to join. And I think we're over 100 or so. So let's go ahead and dive in. As I said, good morning, good afternoon to everyone on the call. We very much appreciate your joining us today. My name is Chip Lyons, and I'm the president and CEO of the Elizabeth Glaser Pediatric AIDS Foundation. I think, as you know, Evidence to Action, which is what we call this webinar series, we hosted EGPAF, which just allows us an opportunity to dig deeper into various aspects of the global work we're doing at the foundation, and we hope and hear that it is of interest to others as well. Today, Dr. Lynne Mofenson is going to present the latest data on children and COVID-19. Dr. Mofenson has been with EGPAF since 2014 and previously led the maternal and pediatric infectious diseases branch at NICHD at NIH. I think Lynne and her work are well known to all of you. One or two quick points, a housekeeping point, although I don't know if this is necessary. I think everyone's become very practiced at using Zoom over the last number of weeks, but everyone is muted. We are going to open it up for questions in the last, say, 10 minutes of the hour. And we'll be teeing up questions that come in through the Zoom Q&A chat function. I think folks know how to do that, but to ask a question at any point during the webinar, click on the Q&A or chat box at the bottom of your Zoom screen. You enter a question, hit send. This is going to then be managed by the webinar hosts. If you have any problems on connectivity or sound, you can email publications@pedaids.org and someone will be able to help you out. I think everyone knows EGPAF's mission is quite focused on fighting for an AIDS-free generation. It's just as urgent as ever in what we're going through now. In trying to manage COVID-19, not just as a foundation, but as with other partners as a global community. Among the things EGPAF can contribute as we deal with these new challenges are some of the hard-earned, quite painful lessons from the ongoing battles against HIV, AIDS, and TB. And a particularly, to my mind anyway, poignant one is just the crucial importance of, from the outset, establishing a focus on children, be it in research, treatment requirements or possibilities, or vaccines. In the early days of HIV, thousands of children were infected, hundreds died before we reached the conclusion children are not just small adults. They need to be treated differently. They need to be understood differently. They need different regimens. They are affected differently. And in this COVID epidemic, that lesson has to be, we don't want to have to relearn that all over again. So today we look forward to this discussion and hearing from Lynne on how we can prioritize the needs of children as the COVID pandemic continues to evolve. I'll turn it over to Lynne, Dr. Lynne Mofenson. She has just been a stellar champion for the needs of pregnant women and children throughout her career, and of no surprise, she is continuing to do just remarkable work monitoring pediatric COVID-19 globally. And we're really pleased at this opportunity for Lynne to share some of that work with you today. So Lynne, over to you, please, and thank you.
Okay. Hi, everybody. So I'm going to present the evolving picture of COVID-19 in children. And just to note, as I did on the previous webinar, that data continue to be preliminary. Some are of poor quality. They change almost daily. And that little kid with the fire hose coming at her, that's the way I feel. It's a deluge of data that's coming in. And so things really do change almost every day. So I want to start talking about the epidemiology of COVID-19 in children. And I just want to make a comment about race ethnicity. So in the US and the United Kingdom, COVID-19 disease is more common among Black and ethnic minority adults. But when you go to look at children, there are really pretty limited data, and actually most pediatric studies don't even report race and ethnicity. But there are 5 studies that suggest a similar race ethnicity disproportionality in children. From Chicago, 474 children were tested, 25 or 5.2% were positive, 6.8% of Black, 6.6% Hispanic, 1.7% white, and on logistic regression, Black race and older age were risk factors. New York City, 2 studies, 96 children hospitalized with COVID-19, 56% Hispanic. Texas, a recent publication, 57 children, 37% Black, 46% Hispanic. And in the United Kingdom, a report from King's College, 9 of the 12 children were Black or other ethnic minority. So this racial disparity may reflect socioeconomic and environmental factors that increase exposure. That's highly likely. Also, a higher prevalence of chronic comorbidities such as hypertension in minority populations. This is more relevant to adults, or some undefined biologic factor. However, the disproportionate representation of children in color in both the US and the United Kingdom is concerning given the expansion of the pandemic to Africa. And just a comment that at minimum, studies of SARS-CoV-2 in children, as well as adults, should be reporting on race ethnicity, and we need to look at the reasons for this disparity. So let's talk about the prevalence of COVID-19. It's been cited as 1 to 2% of all cases, but this is based on initial data from China. And although you wouldn't think it, there's actually no easy way to get global age-related data for the pediatric age group. And when you actually examine individual data by country, you see the prevalence is actually higher than the often cited 1 to 2%. Additionally, there may be underreporting from Africa. So this is the prevalence of COVID-19 reported in children from 13 countries. And you can see I had to go to 13 different websites to be able to collect this data because the global websites don't have it. So there's a total of about 2.6 million COVID-19 cases, out of which 108,105 or 4% were pediatric. It varied from 0.4% in Africa to almost 14% in India. And of the countries that had a breakdown between 0 to 9 and 10 to 18, it was 1.2% 0 to 9 and 2.3% 10 to 18. And I just want to point out that the reporting in Africa of 0.4% is very different than the others and really does suggest some underreporting. And my big comment is it should not be this hard to get age-related data. So among children with COVID-19, it's difficult to get disaggregated data to evaluate proportional representation by age. These are data from 5 different countries' studies on about 12,500 children. And you can see even the age breakdown isn't consistent. We have under 1 year, and then it goes 1 to 4, or 1 to 5, 6 to 10, 5 to 10. So you can't really combine everything, but if you put this all together, about a third of the cases appear to be 0 to 5 years. And over half of the cases appear to be 10 to 18 years, so in adolescence. However, there's a caveat here because younger children may be, have less typical symptoms and therefore less likely to be tested. So why is there a low prevalence in children? So surveillance data have predominantly reflected individuals who are diagnosed with disease and hence reflect selective testing of only the most symptomatic persons. But children are less likely to have typical symptoms. So is the low incidence in children because they're more likely asymptomatic or have atypical or mild symptoms and are less likely to be tested? Or is the low incidence because they are engaged in mitigation measures such as closure of schools, and therefore they're less likely to be exposed to infected individuals? Or is this reflective of a true lower susceptibility to infection compared to adults? So this is data from a systematic review that's in preprint right now that is actually very good. And it looked at all of the contact tracing studies, that's taking an index case and looking for secondary infections, and also population prevalence studies, either using virologic testing or serologic testing. And they identified 18 studies, 9 contact tracing, 8 population screening, most from China, and then 1 each from a variety of countries as shown on this slide. So looking at the 8 household contact tracing studies, preliminary data suggest a lower odds of infection in children. And you can see there's heterogeneity between the results of the studies, and you can see also the number of infected children and the total number tested, the number of infected adults and the total number tested. And overall, child contacts, defined as that should be age less than 18 to 20 years, had a 56% lower odds of becoming infected after contact with an infected individual than did adult contacts. And when they included only better quality studies, it really didn't change this very much. The odds ratio was 0.51, so it went to a 49% lower odds. And there were insufficient data to be able to explore differences between younger children and adolescents. The population-based studies were more heterogeneous and had mixed results, making it insufficient to draw conclusions. So of 2 viral detection studies, 2 national seroprevalence surveys in the Netherlands and Spain also showed lower prevalence in children than adults. However, 2 viral detection studies in Stockholm in the UK and 2 municipal seroprevalence studies in Germany and Switzerland showed the prevalence of infection was similar in children and adults. And there's significant uncertainty of the estimates, and issues include when were the surveys done and how did that match up with the timing of COVID-19 interventions. So I want to talk briefly about cell entry because this is important to talk about susceptibility. And we now know there are 2 cellular proteins on the cell surface that are involved in viral entry: the ACE2 enzyme, angiotensin converting enzyme 2, and a type 2 transmembrane serine protease inhibitor called TMPRSS2. And that TMPRSS2 expression can significantly increase the cellular uptake of coronavirus. So the spike protein on the virus binds to ACE2 on the surface of the target cell. That cellular protease binds to and cleaves the ACE2 receptor and cleaves the spike protein, which activates it and primes it for cell entry. And then the cleaved ACE2 and activated spike protein enables cell fusion. So children may have lower levels of nasal ACE2 than adults, which could potentially make them less susceptible to infection or replication. And these are data from a retrospective examination of stored nasal epithelium from 305 people aged 4 to 60 years from a study a couple of years ago evaluating nasal markers of asthma, and about 50% had asthma, 50% didn't. And they evaluated ACE2 enzyme gene expression in stored samples. So the ACE2 enzyme gene expression was age dependent, being lowest in children under 2 and then increasing with age, and children under 10. And children under 10 were significantly different than all the other age groups. And this was independent of sex and asthma. Another study also found lower levels of ACE2 in the nasal epithelium, but also TMPRSS2, both nasal and bronchial. And this study used public gene expression data sets to look at the differential expression of the genes for both of these proteins in nasal and bronchial airways relative to age and certain diseases. So you can see in the figures that children in black had a significantly lower expression of both ACE2 and TMPRSS2 in both the upper airway and the lower airway compared to adults. And expression of both of these proteins in lung biopsy tissues was significantly upregulated in smokers and persons with COPD, and both of these are associated with more severe COVID-19 disease. So what about transmission of SARS-CoV-2 from children to other people? So the role that children and young people play in the transmission depends on multiple factors. Depends on the risk of exposure to an infected individual, and children are less likely to be exposed during mitigation interventions. The probability of being infected on exposure, and we just talked about children may have lower susceptibility. The extent to which you develop symptoms, children are more likely asymptomatic. The propensity to make potentially infectious contact with others. And as schools reopen, there may be an increase in this possibility. And the extent to which a viral load develops sufficiently high enough to transmit and is durable. And there are actually mixed data on viral load in children and adults. Some data suggesting it's similar, some data suggesting children may have a lower viral load. So these are data from a COVID-19 investigation in schools in Australia. And they had 18 students and staff from primary and high schools that had diagnosed COVID-19, and they then did a contact evaluation. 735 students, 128 staffs were close contacts, and of those who agreed to participate, 288 had RT-PCR swab taken 5 to 10 days after last contact, and 96% had blood samples taken. And of those evaluated for infection, only 1 of 288 had a positive RT-PCR, and only 1 of 96 students with a negative RT-PCR had SARS-CoV-2 antibody, giving you an overall prevalence of 2 out of 735, or 0.3% of the students, and none of the staff having possible secondary infection from exposure to the case. So this suggests that spread within the schools will not be a problem. However, we're right in the midst of a grand experiment, and just within the last couple of days, there have been reports from a number of different countries about opening school and then finding a spike in cases, causing closing of schools, including in France, South Korea, and Israel. And in the report from Israel, it said there were 130 cases at a single school. So this suggests that school closings are important to do. So I think we'll find out in the next couple of months exactly what we will see. So I want to talk and turn about clinical findings in children. This is data from a systematic review of SARS-CoV-2 publications in children. It included 62 studies, 3 reviews, and almost 7,500 children. It's a very nice review, and I refer you to it. The mean age of children was 7.6 years, 52% were male. Most came from Italy, the US, with a little bit fewer from China. Most of these children were exposed within their family, and only confirmed cases were considered in this review. So first, the data continue to show that children generally have mild to moderate disease. 57% of children were either asymptomatic or mild. 96% had moderate disease. Only 2% had severe disease, and this contrasts with adults where 15% have severe disease. Children have fewer symptoms than adults, most commonly fever and cough, and what you see on the left is from the systematic review, the different types of disease symptoms, and on the right, you see data from the US, from the MMWR report on disease symptoms in over 10,000 adults. And what you see is that there were lower rates of all symptoms, including fever in blue and cough in orange, although these were the most common. It was less common than in adults, and much less dyspnea in gray than in adults. Consistent with less severe disease, the laboratory findings in children with COVID-19 are less abnormal than in adults. And again, on the left, you see the systematic review, laboratory findings. And on the right, you now see data from a large study in China, over 1,000 adults, where they gave detailed information on their laboratory findings. So there were lower rates of lymphopenia in yellow, and lower rates of elevated CRP in green. And both of these are associated with more severe disease in adults. So 13% versus 83% lymphopenia, 31% versus 61% elevated CRP. And finally, consistent with less severe disease, children were less likely to require ICU or significant treatment. Again, we've got the meta-analysis on the left and the report from Chinese individuals on the right. And what you can see is that children were less likely to require oxygen in blue, ICU admission in orange, or mechanical ventilation in yellow. And they were less likely to require adjunctive therapy, such as antibiotics in green, steroids in kind of pinkish, and IVIG than adults. And the mortality was significantly different, 0.08% overall in the children, 1.4% overall in the adults. So do symptoms differ in the youngest infants compared to older children? So they were able to look at this. They had data from 11 studies on 25 newborns and infants less than 3 months. And they're very rare reports here. And they found a higher proportion of newborns and children aged less than 3 months had severe disease than older children. So 88% of the newborns and infants compared to 96% of the children overall. So the younger children a little bit more severe, and you can see 12% had severe disease compared to 2.7% in the older children. Newborns and infants aged less than 3 months were less likely to have fever and cough, but more likely to have dyspnea than older children. So we've got the infants and newborns on the left, the overall children on the right, and you can see that dyspnea in green was most common in the newborns and infants compared to 8% in the overall children, and fever and cough were less usual in the infants than they were in the older children. Newborns and infants also had lower markers of inflammation than older children. Again, we've got the newborns and infants on the left and overall children on the right. And leukocytosis, high white count in blue, was more common in the newborns and infants than in the overall children. And the inflammatory markers, CRP in green, was lower than seen in the overall children. So they have a higher white cell count, less lymphopenia, about the same lymphopenia, but less inflammation. And newborns and infants were less likely to require specific treatment, but more likely to go to the NICU. So we are comparing newborns and infants to overall children. So blue is children who require only symptomatic treatment, and that 52% of the newborns and infants compared to 21% of overall children only had symptomatic treatment. However, admission to the ICU, the NICU, was 8% compared to 2% for the PICU in the children overall. And this may be because neonates are more likely to be preterm if they're born to mothers with COVID-19, or may be admitted to the NICU solely for observation due to the COVID-19 in the mother. So I want to talk a little bit about comorbidities and hospitalizations in children. Underlying conditions in children hospitalized with COVID-19, while less frequent than in adults, still occurs in a significant proportion. So 92% of hospitalized adults had at least one underlying medical condition, most commonly hypertension, obesity, metabolic disease, and cardiovascular disease. And this contrasts with 61% of hospitalized children with COVID-19 having an underlying condition. And the most common here were obesity, asthma, and neurologic disease. So talk a little bit about some of these underlying medical conditions. Asthma, while it is one of the most common comorbidities in infected children, at least in the studies published to date, does not appear to predispose children to infection or increased hospitalization risk in those who are infected. And interestingly, the nasal epithelium of children and adults with asthma has decreased ACE2 gene expression compared to those without asthma. However, this could change as more data comes in. With cancer, there was a report from Memorial Sloan Kettering in New York City where they screened 178 children with cancer, found 11% infected. Only 5% of these required hospitalization for symptoms. So it doesn't necessarily mean severe disease even if you have cancer. There's no data on the issue of SARS-CoV-2 in malnourished patients yet. But it's clear that obesity, both in adults and children, is associated with increased morbidity and mortality of COVID-19. And obesity is associated with chronic low-grade inflammation and a disrupted immune response, which may account for this. What about HIV? So this is the data on COVID-19 and HIV this is really through about 2 days ago. There's been some additional published reports since then, but it doesn't really change the findings here. So 22 reports, 182 HIV-infected persons with co-infection, all adults, 98% on treatment, and a variety of different treatments, as you can see. Most had a CD4 over 300, very few were immunosuppressed. Of those that had viral load data, 94% were suppressed. A significant proportion of those hospitalized had comorbidities, and most had mild to moderate disease. 4% required mechanical ventilation, and there were 12 deaths for a mortality of 6.6%. And the overall COVID-19 outcome in HIV-positive adults seems relatively similar to overall adults of similar age, with mortality associated with comorbidity and age, and not HIV per se. There are no data on children with HIV and SARS-CoV-2 to date. So what do children with severe COVID-19 look like? And this is a cross-sectional study of 48 children admitted to 46 North American PICUs between March and April. 83% had pre-existing underlying medical conditions, so similar to adults. 73% presented with respiratory symptoms. 38% required invasive mechanical ventilation. So these are really the sick kids. And overall hospital mortality was 4.2% compared to the 0.08% in the systematic review. So while children have milder disease than adults, they can be extremely ill, and if admitted to the ICU, have elevated mortality. These are data from our local area, Washington, D.C. 177 children with COVID-19 were seen at D.C. Children's Hospital. Most weren't hospitalized, but 25% were. 5% needed critical care, including mechanical ventilation in 4. Again, comorbidity, more common in those hospitalized, 63% versus 32% not hospitalized. The median age was 9.6 years, but the youngest children, less than a year, and the oldest children, 15 to 25, were most likely to need hospitalization in brown, and the critically ill patients in green were more likely to be adolescents and young adults. So adolescents and young adults with COVID-19 may be more likely to have that cytokine storm picture that we see in adults with critical illness. So I want to move on and talk about the evolving spectrum and the new disease that's been reported temporally associated with COVID-19 called multi-system inflammatory syndrome, or MSIS, or people use other abbreviations. And this is a picture from the Washington Post of a healthy 12-year-old who had coronavirus, got better, and then developed MSIS and actually had 2 cardiac arrests and luckily is doing well now. So in mid to late April, reports from Western Europe identified a new febrile pediatric entity involving systemic hyperinflammation, multi-organ involvement, abdominal pain, GI symptoms, features similar to Kawasaki disease with prominent cardiogenic shock and myocardial dysfunction. And most of the children tested either RT-PCR positive or had IgG/IgM antibody to SARS-CoV-2, even though they may not have had any symptoms. By early May, cases were reported in New York City, with the health alert issued May 4th by the city and then by the state by May 6th. And by May 12th, there were 102 cases reported in New York with 3 deaths. May 14th, CDC issued a health advisory with a case definition and requested reporting of cases in the US. And May 15th, WHO issued a scientific brief, a preliminary case definition, and requested reporting to a global clinical data platform and set up a global collaborative research forum that actually meets once a week on Thursdays for an hour with researchers from around the world to talk about their studies and how to collaborate. By May 26th, this was reported in children from 23 states in the United States. So since the very first published report in late April, there's been an explosion of publications from the US and Europe, 24 in less than 4 weeks, pardon me, including 2 that were yesterday. So temporally, this disease begins to manifest approximately 1 month after the peak of COVID-19 cases in Europe and the US, rather than being contemporaneous with the epidemic peak. Most of the children have evidence of SARS-CoV-2, but not necessarily current infection, but antibody indicating past infection, suggesting a post-infectious inflammatory process that may be immune complex mediated. And it has some resemblance to Kawasaki's disease, Kawasaki's shock syndrome, and potentially resembles the later phase of adult COVID-19 with the cytokine storm, hyperinflation, multi-organ damage, including myocarditis and acute kidney injury. So this is Kawasaki's disease, which is a self-limited vasculitis of childhood that's thought precipitated by some common infectious pathogen that results in an immune-mediated response in children who are genetically predisposed, with the most important complication being coronary artery aneurysms. And the red flags of Kawasaki's disease, you need to, for that diagnosis, you need to have at least 4 of conjunctival injection, peripheral edema, cervical lymphadenopathy, fissured lips, strawberry tongue, or rash. And the shock syndrome can occur as well. And you can see down here the coronary artery aneurysms that can occur. So there are differences between Kawasaki's disease and this syndrome. The demographic features are different. Kawasaki's disease, 50% are under 2 years, most under 5 years, compared to a mean age of 8 to 10. Kawasaki's disease is more frequent in Asia, Asian children, but this disease has not been seen in Asia yet. And in several series, it's more common in children of African ancestry. Clinical features include more abdominal pain, diarrhea, vomiting, and multi-organ involvement. Cardiac features are prominent, showing moderate to severe cardiac involvement, greater than you usually see with Kawasaki's. And laboratory features are distinct with hyperinflammation, and I'll show you this on the next slide. just published yesterday evening was the largest case series, 58 children from 8 hospitals in England. They all presented with fever, nonspecific symptoms, most commonly GI and inflammation. 13 had symptoms meeting the definition of Kawasaki's disease with or without shock. 23 had fever and inflammation without shock or Kawasaki's disease, but 29 developed shock and myocardial dysfunction. 23 required mechanical ventilation. 8 developed coronary artery aneurysms, and 78% had evidence of current or prior SARS-CoV-2. And they compared this to a database from Jane Burns of over 1,000 children with Kawasaki's disease to evaluate similarities and differences. And this shows you the list of characteristics compared to the multisystem inflammatory disease, Kawasaki's, and Kawasaki's shock. So the kids with multisystem inflammatory syndrome were older, 9 versus 2 to 4, had higher white count, 17 versus 13, higher neutrophil count, lower lymphocytes, lower hemoglobin, lower platelets, lower albumin, and most importantly, markedly elevated inflammatory markers, significantly higher than seen with Kawasaki's disease. This little graphic shows you the manifestations of the multisystem inflammatory syndrome. This comes from the case series that was the largest, 35 cases from France and Switzerland, and the percentages represent the percentages seen in that case series. And in red, you see the signs and symptoms that are consistent with Kawasaki's disease, also seen with the multisystem inflammation, and in black are the signs that are rare in Kawasaki's disease, and that includes this prominent left ventricular dysfunction, and also note neurologic signs in 31%. Treatment of this is primarily supportive care of acute organ dysfunction and shock, and most children improve with intravenous immune globulin with or without steroids, which act to modulate cytokine activation. And other immune modulators have been used if non-responsive to this primary therapy, including blockers of IL-1 and IL-6. And interestingly, this has not been reported from Asian countries or from Africa, but surveillance for the syndrome has been limited to non-existent until now. So there's a possible widening spectrum of disorders in children with SARS-CoV-2. You have, this should really be the bottom of the triangle, generally mild or asymptomatic disease. Above that, you may have some of these children with mild or asymptomatic disease who have persistent fever and inflammation. Above that, you may have some who develop symptoms of Kawasaki's disease, and then finally a small minority develop this pediatric inflammatory multisystem syndrome temporally associated with SARS-CoV-2. And this is just for your information, the WHO website with the preliminary case definition, which I've listed, and the ability to do global reporting to this clinical data platform that if you're seeing patients, it would be very good if you reported to, so that we have a global picture. So while COVID-19 seems relatively less frequent and more benign in pediatric populations, severe cases have been reported, and the appearance may be biased by our incomplete knowledge of this new disease. Similar to adults, children with comorbidities appear overrepresented in those with more severe disease, so they need more careful attention if they get sick. And this recent emergence of the multisystem inflammatory syndrome in children with either current or past SARS-CoV-2 infection demonstrates how disease due to SARS-CoV-2 in children remains yet to be defined. And I just wanted to end with a few studies talking about the impact of COVID-19 response on HIV and maternal and child health services, kind of going at each other with those two cars ready to crash. And these are 3 modeling studies. The first study was in Lancet Global Health, And they modeled 3 scenarios where coverage of essential maternal and child health interventions were reduced by a small amount, 5%, a moderate amount, 10%, a large amount, 15%, and that child wasting also increased in 118 low and middle income countries. And on the left, you see the number of child deaths per month, and on the right, you see maternal deaths per month, and in pink, you see the additional excess deaths. So depending on the scenario, 1, 2, or 3, there could be an increase of 9.8 to 44.7% in under age 5 child deaths per month, and 8.3 to 38.6 increase in maternal deaths per month across 118 countries. This was modeling coming from the group that does UNAIDS, Avenir Health, and they examined the effects of a 3 or 6 month service disruption due to lockdown or health system capacity constraints on HIV incidence, including mother-to-child transmission in 4 African countries: Zimbabwe, Uganda, Mozambique, and Malawi. And this shows you the percentage increase in new child infections. So they noted that PMT-CT coverage is high in most countries with few new child infections, and that any disruption to services could lead to large increases in new child infections, including about 10% if disruption to only new patients coming into ANC, to 50% for a 3-month disruption if it disrupts all PMT-CT, and 100% for 6-month disruptions to all services. And the final one looked at 5 intervention scenarios for COVID-19: no action, mitigation, suppression and then list of suppression, and unmanaged suppression and well-managed suppression, and the potential service disruptions associated with each of these. And then they estimated the impact on extra deaths due to HIV, TB, and malaria from 2020 to 2024. So for HIV, up to a 10% increase in HIV deaths was estimated, and this was primarily due to ART interruption during periods of high or extreme health system demand, in the little purple box here. For TB, up to a 20% increase in TB deaths, primarily due to reductions in timely diagnosis and treatment of new cases from long periods of unmanaged or even well-managed suppression interventions that limit activities, and that's in the little brown box there. And then for malaria, up to a 36% increase of malaria deaths, primarily due to reduced prevention activities such as distribution of insecticide-treated nets during all phases of response. So all of these illustrate the critical importance of maintaining maternal and child health services and HIV, TB, and malaria-specific services as much as possible as part of the COVID-19 response to reduce the broader potential public health impact of our interventions for COVID-19. And that's it. Thank you very much. And we are open for questions.
Wonderful. Thanks, Lynn. This is Catherine Connor from EGPAF, who's just going to help moderate. And you are amazingly on time, Lynn. So thank you very much with all this information to share. The Q&A box is open. While people are starting to put questions in there, I do just sort of have a general reaction and a question for you, sort of looking at the variety of research questions you covered in your presentation. All right, and I know you noted at the beginning also that some of the quality is, you know, obviously kind of under question, and there's emerging topics all the time. Are there any particular either treatment interventions or interventions, age groups, or even vaccine possibilities that you're sort of particularly concerned may not get enough attention, or we need to make sure that we're pushing for because this population is so difficult sometimes to get evidence and scientific information about?
Yeah, so I think that, what I showed on the data of the lack of disaggregation by age and race, ethnicity, really illustrate the issues of poor reporting of disease in children. And I'm very concerned about the lack of pediatric reporting in Africa. And we don't know whether that's because the disease isn't being seen in children there or it's not being picked up. And we really need good infection and prevalence studies to determine if children are really less susceptible, and if they are, why. We need to understand more about this multi-system inflammatory syndrome. It just shows us that we're just at the beginning of understanding this infection. And I think it's really critical that children be included in trials of treatment and particularly vaccine treatment, because children get critically ill, and if we don't know what dose of remdesivir to give, that's a problem. And vaccines, because if children are a major issue in terms of transmission, we really need to target vaccines to them. So if we don't have the studies include them, we won't be able to do that. And then finally, we need data on the overall effects on the health system. I showed you all of these modeling exercises, but we really need to know, did that really happen or not? So those are just some preliminary thoughts.
Thanks, Lynn. And actually, your last point leads really nicely into one of the questions we got through the Q&A box. So I have put that up on the screen, but, sort of asking about the modeling data on disruptions to routine health services and why aren't they making their ways into some of these kind of public policies. Is there something more we need to be looking at when we look at these modeling presentations as you showed us?
So these modeling exercises, I mean, the initial COVID models really didn't include children or any issues related to children. And I think that's because people thought children weren't a problem and didn't get sick. So these modeling pieces that I just showed you are really just within the last week or so that people have begun to pay attention to. And certainly one, important piece is the issue of schools, reopening of schools. And the question about looking at COVID impacts on overall maternity morbidity and mortality, well, I think that's what that first modeling study did. It looked at overall maternal and child health mortality and what do our interventions do to that. So I think it's beginning to be looked at.
Thanks, Lynn. Another question that was asked, it was, again, I think this may have been more slide dependent. I've released on the screen as well, but how comparing these findings with other coronavirus associated diseases, and are they being looked at with that granularity?
So they really haven't. I didn't look this morning at pediatrics, but I had a question about SARS in pregnancy, and is this different with COVID-19 than with SARS-CoV-1 or with MERS? And when you look in the literature, there are 13 cases of pregnant women with MERS and maybe 25 cases in the literature on SARS-CoV-1. And those cases suggest that pregnant women do worse, whereas the data on COVID-19 to date suggests that maybe they do the same. But that just illustrates the fact that, back then, pregnant women, children really did not get a lot of attention. And so I don't know that there's a huge amount of literature addressing this.
Thank you. We just had another question come in, and it still kind of goes back. I remember the last time you did this presentation, I think sort of assessing this idea of safety, that children are safe or not. I think you present a lot of sort of information that kind of shows you the different age groups and stuff, but do you kind of believe that sort of what we're seeing more in the news, again, this idea that children are safe?
Yeah, I think, this is where the hose of disease, the hose of publications coming in. I would say that when I initially was reviewing the data, it looked like children were more likely to be asymptomatic, have mild disease, not get sick. But as you could see with this particular update, children can get very sick and even die with this disease. So while getting very sick may be less frequent than adults, it does occur. And so that's not safe. And then the second piece is whether or not children are involved in the dissemination of disease. And I think you could see from that really nice meta-analysis that when you look at the prevalence data, you know, you can't make head or tail yet. And when you look at the school data, you know, the school contact investigations look really good. And then you go and there's a press report that Israel reclosed their schools because of outbreaks. So I don't think we know yet anything about what role children play in the epidemic as a whole, and whether they are less susceptible or not. Those are important questions to answer.
Thanks, Lynn. I'm jumping in because I'm curious about something you just said. But on the antibody side, have there been? I mean, most of the information you presented was on sort of either current infection or the sort of the conditions showing up after infection. Is antibody testing being widely done amongst children at all? I know it's barely just being rolled out with adults. I'm just curious if you've seen a lot of antibody information coming through pediatrics.
Yeah, the antibody information is problematic. I mean, it depends on the tests that you're using. There are like 30 or 40 antibody tests out there that have not been validated. And some of the tests I read, you might as well flip a coin as to whether they are correct or not. So we really need a better validated test. And there have been some seroprevalence studies. I think I showed you in that meta-analysis and in the Australia school evaluation. But until you know that antibody test is actually valid and what the false positives and false negatives are, it's hard to be able to really comment. And remember also that if you have a low prevalence condition, which SARS-CoV-2 is, that even a very good test has a high rate of false positive or negative responses. It's really in a high prevalence environment that you see almost perfect sensitivity and specificity. This is similar to HIV testing.
Yeah. The next question that's come in is actually on sort of any models of impact on COVID-19 on childhood immunization.
So there haven't been models done, but there was a MMWR that CDC published showing that children that immunization rates are falling. And it's not just immunization rates. There was another study reported, I think it was from Italy, showing that pediatric visits to the emergency room have decreased. I think people are afraid to go into the medical system and afraid to bring their kids in for vaccines. So I do think that is being seen, and I would refer you, the MMWR was within the last 2 to 3 weeks, I think.
Thanks. Next question is on chloroquine. Is there any information on chloroquine in the management of COVID that could motivate continued use of the molecule at all?
Well, we have
Crazy.
data, and then you've got personal opinion. I'll give you my personal opinion. My personal opinion is that it is useless. The data, there were some initial reports saying that chloroquine or hydroxychloroquine with azithromycin was effective in reducing mortality and reducing morbidity and decreasing hospitalization. These were small studies that came from France. And then following that, there were a number of studies that looked at different dosing that found high dosing was a problem. Both of these drugs cause an increase in QT interval and can cause cardiac arrhythmias. And I think that the data that have come out from the VA, from randomized trials, and from, I think most recently looking at hydroxychloroquine as prophylaxis, pretty definitively show that it is really not that helpful. Whether or not it's harmful is another question, and the study that showed that was an evaluation of electronic medical records, and I'm sure everyone's aware that both Lancet and New England Journal retracted these articles because the database was questionable. The database was questionable, but I think the other studies indicate that it may not be harmful, but it is not that great either. I think remdesivir is the important drug right now, and people should know that Gilead is evidently planning a pediatric phase 1 trial soon, as well as a trial in pregnant women, so that's really good.
Thanks, Lynn. We have 2 minutes left. We're out of questions in the Q&A. I do want to remind people we will be posting this webinar online, the recording of it, as well as if there are questions people have afterwards, the email is on the screen. I have one last question that I'd like to ask for Lynn. And again, apologies if I missed it, but I think when you mentioned all the information coming out, so I know that you mentioned the article about the girl who had the 2 cardiac arrests and now is doing better. And even today in the Washington Post, there was a mention of some of the lasting impacts of COVID. Are there any plans to do any longitudinal studies, or tracking a cohort or anything of children who have had the impacts or tested positive? Is just any longitudinal viewpoint on COVID-19 right now?
I think that I know that there's a longitudinal study in Europe. I think there's a longitudinal study in the US. The pediatric investigators, actually many of them HIV investigators, have jumped right in. And there's a lot of studies going on. It's just that they're not necessarily coordinated. And that's why I think this WHO group trying to bring everyone together to coordinate it will be important. I see there's one more question.
1 minute, perfect timing.
Yeah, saying, are there data that explain the shorter course of disease in Africa? No, I don't think that we understand this very well yet, and I don't know whether partially testing is the issue, particularly in kids. Are they not being tested? And reporting. I just don't know, and I certainly think that studies to evaluate this in the African context is really important in adults, in children, and in pregnant women as well. One last question was, are there any studies that demonstrate reduction in children's vulnerability to COVID-19, and what's a potential strategy? So the reduction in vulnerability, that goes back to, are children susceptible or not, and does it matter whether your ACE receptor is lower in your nasal mucosa or not? Those are things that still need to be able to be studied, so I don't have an answer to that. And I see Jeannie Collins just said Penta's trying to pull together existing pediatric cohorts and registries across Europe and Asia to look at long-term outcomes. So that's really good.
Great news. Well, I want to thank everyone who joined us today. I don't know if Lynn, you have any final comments you want to make?
No.
I think you've given us a lot to think about. So, but I want to thank everyone for joining us today. Again, one more reminder that this will be posted, and if you have additional questions, we are happy to address those through the website, through the email address on the screen. But thank you, everyone, for your participation today, and we'll be doing more of these educational webinars in the future. So thank you all, and have a good day. Thank you, Lynn, for once again taking the time to put this all together for us.
Okay. Thank you. Bye-bye, everybody.
Bye. Thanks.